Hello everyone, myself Dr. Harsh Kumar Pandey, Assistant Professor of Cardiology at Even Mehta Institute. So today I'm going to discuss about the assessment of block in the conduction system, and this is the first part of this lecture series. So assessment of the block in the conduction system does not mean that we have to recognize the block in the ECG. We have to accurately localize the block in the conduction system so that we can plan the patient, whether the patient needs medical management or whether he needs a pacemaker. So the scope of discussion will be, we will first discuss about the basics of the conduction system. Subsequently, we will go one by one to the different stations of the conduction system, the SA node, intratracheal fibers, AV node, and then subsequently His-Purkinje system. The last part of this lecture, this His-Purkinje system, I will discuss in a separate series. So the normal conduction system, so we have a SA node. This is situated at epicardial location at SVCRA junction. And through the intratracheal fibers, it is connected to the AV node, and then subsequently backbone bundle connected to the from the right atrium to the left atrium, and the AV node gives rise to the His-Purkinje system. The His bundle will divide into the left bundle, right bundle, and the left bundle will have three separate fascicles: left interfascicle, left septal fascicle, and the left posterior fascicle. And at last we have the Purkinje fibers. So the impulse is going to start from the SA node, and through the various of these conduction fibers, it will travel to the intratracheal fibers, AV node, and then the His-Purkinje system. At last, it reaches to the ventral myocardium, and it will give rise to the QRS complex. So it is important to know that from the His bundle and the left bundle, right bundle, they have the conduction velocity of around 2 to 3 meters per second, and the Purkinje fiber, they are having velocity of around 4 meters per second. And the backbone bundle have the velocity of around 1.5 meters per second. The atrial muscle fiber and the ventricular muscle fiber, they are slowly conducting fibers, and they are having conduction velocity of around 0.5 meters per second. So the important thing is that whenever there is a delay or dissociation or any refractoriness increased inside the conduction system, the impulse will travel, they will travel through the muscle to muscle, either in the atrium or in the ventricle. And because of this slower conduction inside the atrium and the ventricular muscle fiber, there will be delay in the part of their conduction. So the P wave morphology or P wave duration, the QRS morphology or the QRS duration will be changed. So because of this efficient conduction system we are having, so our P wave is less than 120 millisecond and our QRS is also less than 120 millisecond. Coming to the pacemaker of the conduction system, so pacemakers, there are different pacemakers inside the heart. The predominant pacemaker is the SA node, which discharges at about 60 to 100 beats per minute. If the SA node does not fire, then AV node will take place as a function of the pacemaker of the heart. It will discharges at about 50 to 60 beats per minute. If the AV node also not functioning, then the His-Purkinje system will take over, and that will discharge by the rate of 30 to 40 beats per minute. So it is also important to know what are the different innervation of the conduction system. So the SA node level and the AV node level, they are highly innervated with the sympathetic and the parasympathetic nervous system, whereas the His-Purkinje system, they are very minimally innervated with the parasympathetic and some minimal amount of the sympathetic innervation they are having. So important thing to understand is that whenever you stimulate the sympathetic nervous system either by the atropine or isoproterenol, so you will increase the conduction through the SA node or the AV node. So sympathetic stimulation is going to improve the conduction through the SA node and the AV node, but it have minimal effect on the His-Purkinje system. So suppose there is a sinus node depression or sinus bradycardia, or because of some AV delay there is a Linkebeck phenomenon is happening. If you give atropine to those patients, the sinus rate will discharge faster, the AV node will discharge faster, their refractoriness will improve, and the conduction may become 1:1 from 2:1 sometimes if the block lies inside the AV node. But suppose if the patient is having His-Purkinje system diseased, so at that situation if you are giving atropine, it is going to improve the conduction through the AV node, but it is found so that every impulse is going to reach the His-Purkinje system, which is already diseased, and there is more amount of the refractoriness inside the His-Purkinje system. So whenever the impulse arrives to the His-Purkinje system, they are not able to conduct through the His-Purkinje system, and the conduction system may worse also. So sympathetic nervous system and the parasympathetic nervous system, they have indirect effect on the His-Purkinje system, and they will have a direct effect on the SA node and the AV node. So fourth part, the basic intervals we need to know when we are doing the EP study. So sinus node will discharge and the impulse is going to reach to the through the SA node to the right atrium and the left atrium. So the impulse travels from the sinus node till it depolarizes the full of the atrium. The time taken it will label as a P to A interval. It is roughly around 20 to 50 millisecond. From atrial depolarization, then the impulse will travel through the AV node. From atrial depolarization till the onset of the his system, it will take around 55 to 120 millisecond. It is known as the A to H interval. The his system itself will take some amount of time to depolarize. It is known as the H to H interval. It is roughly around 15 to 20 millisecond. From the his bundle to the right bundle and the left bundle, impulse will travel to the right bundle and the left bundle, and subsequently it will reach the ventricle myocyte. So from the H to the ventricle depolarization, it will take around 35 to 55 millisecond. It is known as a H to V interval. So important thing to understand here is that this all intracardiac intervals P to A to H, H to H, and H to V, they are all the part of this PR interval. So one more important thing to understand here is that the SA-nodal activity is not going to reflect in the scalar ECG. We are seeing the P wave, which is a reflection of the atrial depolarization, and subsequently we are seeing the PR interval, starting of the P to the starting of the R QRS complex. That PR interval will consist P to A to H, H to H, and H to V interval. So among this, if suppose there is a H interval more than 125 millisecond, it is termed as a supraHisian AV delay, and if there is a H interval of more than 55 millisecond, it is termed as a infrahisian AV delay. And one important thing is that in this intracardiac interval, the highest amount of time taken for this conduction is at the level of suprahisian level, that is from the atrial depolarization till the onset of the his activity, that is A to H, that is 55 to 120 milliseconds. So this is important to remember. The AH interval is highest among the intracardiac intervals inside the PR interval. So some basic things you have to know about the cardiac action potential. So cardiac action potential is having phase 0, phase 1, phase 2, phase 3, and the phase 4 phase. So in the 0 phase, there will be opening of the sodium channels. When there is a certain threshold is reached, then the sodium ion channels will goes faster inside the membrane, cell membrane, and then the full defluorescence will take place. Subsequently, there will be phase 1. Phase 1 is known as a early repolarization phase. In this phase, the potassium ion channels will open and then will go from the inside to outside the cell membrane, and the phase 1 will start. And in the phase 2, it is known as a plateau phase. It is because of the some of the amount of the calcium channels. So calcium channels will go inside from the outside of the cell membrane, and because of that, some plateau phase or quiescent phase will form. And the third phase is the repolarization phase. So what happens in the repolarization phase? Or the potassium ion channels will open, and the potassium ion will go from inside to the outside. So the repolarization will start, and at last we will have the phase 4. So in phase 4, it is because of the sodium potassium ATPase activity. So this phase 4 is very important to understand, is that in the action potential, the his Purkinje action potential, that does not have a facility of this phase 4 action potential. So they have phase 4, phase 1, phase 2, and phase 3. They usually does not carry the property of phase 4 action potential. So phase 4 action potential is also known as a diastolic depolarization phase. So this phase 4 is basically, this is the property of the SA node and the AV nodal cells. So they usually will have phase 0, phase 3, and the phase 4. Because of the phase 4 activity, this SA node and AV nodal cells, they can depolarize spontaneously, and they can act as a pacemaker of the heart. And this is because of the funny channel currents, sodium ion channels. Because of that, the SA nodal cell and the AV nodal cell, they can spontaneously depolarize. Whereas in case of his Purkinje level, you can see that they are having invert rectified potassium ion channels. So they basically maintain the resting membrane potential, and because of that, the phase 4 activity will not start in the normal his Purkinje system. But in case of diseased his Purkinje system, this phase 4 action potential can start. So another important thing basic thing to understand, whenever we are keeping a catheter over the his Purkinje system, so we are getting the 3 signals. One is A, one is V, and in between there is a sharp spike signal known as a his potential. So how can we recognize from the surface ECG? The QRS complex will follow the V wave in the AGM, the P wave will follow the A wave in the AGM, and in between those two there is a high frequency spiky signal known as a His potential. So some terminology also you need to understand. Suppose this is a AHV is going on at the sinus rhythm, and suppose at this first point the A came and it does not have any H and V. So what is happened here? So A came, H does not came. So it is termed as a suprahissane level of AV block. In the second thing, A came, H also came, but V does not came. So there is a block below the level of the His. So it will be termed as a infrahissane level of AV block. So third thing, suppose AHV came, in the second beat you can see the A came and there is a 2H came, and followed by sometime V will come or sometime V may not come. So whenever you see 2H potential or a split H potential, it will be termed as a intrahissane level of AV block. So this is the EGM, real-time EGM. So here you can see there is a P wave in the surface in the V1 lead, there is a P wave and a QRS complex. The P wave follows the A wave in the His bundle electrode. The QRS complex follows the V wave in the His bundle electrode, and in between A and V there is a high frequency signal known as a His potential. So coming to the, after this discussion of the basic talk, we will go to the each station. The first station is the sinus node. So the sinus node lies at the SOCRS junction. It is a subepicardial structure and it is situated posterior part of the right atrium. So it is having two kind of cell. One is known as a P cell, another one is known as a T cell. So P cell will form the impulse, and through the T cells the impulse will travel from the sinus node towards the all of the atrial cells. So the P cell will generate the impulse and T cell will transmit the signal toward the atrium. So coming to the sinus nodal exit block, so there are three types of sinus nodal exit block: first degree, second degree, and the third degree. The second degree having two types, type 1 and the type 2. So we'll go for one by one. So first degree SA exit block. So what is happened here? There is a delay in the transmission of the impulse from the sinus node to the atrium. So what will happen here? So impulse will form inside the sinus node, but there will be some amount of fibrosis around the sinus node. So what will happen? The impulse will form, but it will take some time to discharge from the sinus node to the atrium. So there will be some amount of delay from in terms of transmission. But since already we have discussed, the sinus nodal activity does not reflect in the scalar ECG. So this particular finding we are not able to see in the scalar ECG. Coming to the second degree SA exit block, there are two types, type 1 and type 2. In the type 1, how can we recognize in the ECG? The PP interval will be progressively shortens before the occurrence of pause, and the duration of the pause will be less than the twice of the PP cycle. In type 2 SA nodal exit block, there will be intermittent P waves drop out of the rhythm and subsequent P waves will arrive on the time. And the pause surrounding the dropped P waves will be exact multiple of the preceding PP interval. So these two things we will discuss in the later on. So first thing, we will discuss about the mechanism of the type 1 SA Vinkebeck block. We will understand through this ladder diagram. So here the sinus node is discharging at the rate of 1000 millisecond. So the impulse will travel through through the atria, then the AV node, and subsequently to the ventricle. So this is the first beat. So the sinus node to the atrial discharge, it will take some amount of time. So it is here, it is shown as a 200 millisecond. So the PA will form by the duration of 1200 millisecond, 1000 millisecond of the sinus node discharge and 200 millisecond delay at the level of atria. So the PA will be formed by the 1200 millisecond cycle and duration. In the second beat, there will be further delay from sinus node activity to the atrial level activity, and that delay was increased to 100 millisecond. So now the next P is formed by the delay of 1100 millisecond. In the next beat, again there is the delay increased further. Now the delay is increased to 50 millisecond from 300 to 350. That means 50 millisecond increment in the sinus node to atrial activity. So here the P wave will be formed by the 1050 millisecond. So what you can see here, there is an increase from the sinus node discharge through atrial activity by means of first is 100 millisecond, second is a 50 millisecond. So there is a progressively increase from the sinus nodal discharge to the atrial level activity. On the same time, you can see the P wave formed shorter. P wave formed earlier and earlier. The first P wave formed by 1200 millisecond, second P wave formed by 1100 millisecond, and the third P wave is formed by 1050 millisecond. And then the one P wave was blocked. And again, the next bit was resumed. So there was a pause. So the duration of the pause will be less than the twice of the PP cycle length. So how it will be? So it will be 2 into 1000 minus the actual amount of increment, the absolute amount of increment we have to minus from the previous beats. So you can see the increment was in the first beat was 100 millisecond, in the second beat it was 50 millisecond. So total increment was a 150 millisecond. So you have to minus this 150 from 2 into 1000 millisecond of sinus nodal discharge. So it will be 1850. It is less than the twice of the PP interval. So that is what we have discussed prior. So this is one of the example, second degree nodal exit block type 1. So there are PR interval, so PP interval this you can see here this much, and subsequently the PP interval will become shorter and shorter, and that the P was dropped out. So this is, so whenever you are seeing the PP interval is shortening and then P wave is blocked, it is, you have to look for the second degree nodal exit block type 1. Coming to second degree nodal exit block type 2. So here you can see the PP interval is fixed, PP interval is fixed here also, and then there is a drop in the P wave. So there will be a pause, and the duration of the pause will be exact multiple of the previous PP interval. So that is termed as a second degree nodal exit block type 2. Coming to the third degree exit block, so none of the sinus impulses are going to conduct to the right atrium or inside the atrium. So you have to differentiate between the sinus arrest and the third degree nodal exit block. So in case of sinus arrest, so sinus will be suppressed, totally suppressed. They are not going to form any kind of sinus impulse, and the junction's rhythm will take over as a pacemaker function of the heart. In case of third degree nodal exit block, the sinus node will fire, they will form the impulse, but the impulse is not going to transmit from the sinus node to the surrounding atrium. And again, because of that, the junction rhythm will take over as a pacemaker function of the heart. So how will you differentiate both of this situation? In case of sinus arrest and in case of sinus nodal exit block, the P waves are not being formed in one times, and P waves are not being conducted from the sinus node to the atrium. So how you will recognize these things in the ECG is that in case of sinus arrest, the duration of the pause will be exact multiple of the previous PP interval, where in case of sinus nodal exit block type 2, the pause will be exact multiple of previous PP interval. So the natural history of sinus nodal exit block is that there is no evidence to show that the pacemaker therapy is going to improve the prognosis in this group of patients. So what is the significance of this block? So indication of the pacing depend upon the symptoms of the patient rather than the heart rate. Sometimes some patient will have resting heart rate of 30 to 40 beats per minute, but they don't have any symptoms. So you have to treat the symptoms rather than the heart rate. If the patient does not have any symptoms, patient should be kept on medical follow-up. Second thing, if the patient is having asymptomatic pause of more than 2.5 seconds, still they should not be considered for the pacemaker since the patient is asymptomatic. Third thing, if the patient is symptomatic, but still they are having asymptomatic pauses of more than 6 seconds, they should be considered for the pacemaker, but still it is considered as a class 2A indication, not a class 1 recommendation from the ESC guidelines. And last thing is that if the patient having sinus node dysfunction and they required guideline directed medical therapy and their bradycardia is still worsening, in that situation it becomes a class 1 recommendation to put a pacemaker for this group of patients. So what is the reason behind we are kept a value of pause of more than 6 seconds as a target for the pacemaker? So various studies has been done in the past. The first thing is that the Willing et al. They have studied this condition long back in 2009 from Netherlands. So they studied and they showed that there is no loss of consciousness before the 6 seconds of asystole. Another study by Manuzzi et al. They have studied in 1993, and the study from Italy, they have told that in a clinical follow-up of 23 patients for 2 years, if the patient having asystolic episode of 3 to 6 seconds, less than 1% patient develops syncope on follow-up of 2 years. And if the patient having asystolic episode of more than 6 seconds, they resulted in pre-syncopal or syncopal events more oftenly, and they reported incidence of 43% of those patients. So that is why the guidelines have recommended, if the patient having asystolic pause of more than 6 seconds, even though the patient is asymptomatic, they should be considered for the pacemaker. So coming to the station second, that is the interatrial level of block. So as we know, the right atrium and the left atrium being connected by the Bachmann bundle. So these Bachmann bundles are the specialized conduction part of the conduction system. So they run parallelly from the right atrium to the left atrium in a subepicardial fashion, and they transmit the impulse from the right atrium to the left atrium. So there are 3 types of interatrial block. The type 1 is termed as a partial interatrial block. So in that, what has happened here? So you can see this is the system, 3 internodal fiber, and the one is the Bachmann bundle. So impulse through the Bachmann bundle, there is some fibrosis happened over the interatrial fibers of the Bachmann bundle. So because of that, the impulse will travel slowly from the right atrium to the left atrium. So because of slower conduction from the right atrium to the left atrium, the period duration will increase. It will increase by more than 120 millisecond. That you can measure in the inferior leads. So in this particular example, here the P was 125 millisecond. So coming to the type 3, type 2 I will discuss after this. So in the type 3 interatrial block, that is also known as the advanced level of interatrial block. So here what has happened here, it is a full of the Bachmann bundle become fibrotic. So now the impulse will conducted through the atrial muscle fibers. First it will goes down from the interatrial septum towards the downward side, and then subsequently it goes upward. So because initially it will goes down, the infiltrate will show positive complex, and subsequently it show a negative complex. So in case of advanced interatrial block, there will be notch in the inferior leads in terms of positive and negative appearance. So this is here the period duration is 190 millisecond, and there is a notch in the inferior leads in terms of positive and negative waveforms in the inferior leads. In the type 3, it is termed as an intermittent interatrial block. So there will be variable degree of block on the same ECG recording. The finding will be alternating between the first degree interatrial block and the third degree interatrial block. So what is the criteria to diagnose interatrial block is that the P wave in the ECG of interatrial block, it may be transient, it may be occurring in the 1 beat or 2 beat, and subsequently P wave become normal. So it need not to be consistently present in throughout the rhythm. That is the first thing. Second thing, the P wave in the ECG of interatrial block should appear without any associated atrial cardiomyopathy or atrial enlargement. That is the second thing. The third thing is that the P wave in the ECG pattern, it may be reproduced experimentally if at all it has been done. So what is the clinical significance of this interatrial block is that there is in various studies and has been done, and they have shown these kind of patients are higher prone to develop atrial fibrillation in future. If the patient is having advanced interatrial block and they are also having atrial fibrillation, it is known as a bias syndrome. And since the patient having higher amount of higher percent of this kind of patient develop atrial fibrillation in the future, so we have to study whether there is a role of oral anticoagulation before they start developing atrial fibrillation or not. So currently there is no role for starting OAC prior to development of atrial fibrillation in this group of patients. Coming to the third station, that is the AV node. So AV node, and this is the macroscopic view. Here you can see the AV node lies on the lower part of the interatrial septum. It is bounded by the 3 structures: the septal tricuspid leaflet anteriorly, posteriorly by the tendon of Tadaro, and the base is formed by the coronary sinus os. So better we will see in this animation. So this is the interatrial septum, this is the interventricular septum, and this is the triangle of Cox. The posterior boundary being formed by the tendon of Todaro, the base is formed by the CS os, and the anterior boundary being formed by the septal tricuspid leaflet. And the AV node lies at the apex of this triangle, and at the apex it will give rise to the penetrating bundle of the His. Subsequently, bundle of His will divide into the right bundle and the left bundle. So AV node will have some extension, the right inferior extension and the left inferior extensions, and AV node will have some amount of different conduction properties. The upper part will have fast conducting fibers and the lower part will have the slow conducting fibers. Because of this different properties of this AV node, patients of this kind of properties are prone to develop AV nodal reentry tachycardia. So now we are going to discuss types of AV block. So first degree AV block, in that there will be prolonged AV conduction, and in the second degree AV block there will be intermittent AV conduction. So in the second degree AV block can be Mobitz type 1, it can be Mobitz type 2, then 2-stage AV block, it is a separate entity, even though there will be intermittent AV conduction, and then there will be high grade AV block, still there will be intermittent AV conduction, and at last we'll have the complete heart block, and there we'll have no AV conduction. So I have not filled the site of block here. So we'll go one by one of all the situation, and then we will discuss whether we can localize where is the block lies in this particular kind of AV blocks. So AV nodal cells, there are three types of AV nodal cells. From the atria to the AV node, the cells are termed as atrio-nodal cells, and in between there will be nodal cells, and from the nodal cells, then connection to the His bundle, it is known as a nodohesion cells. So particular nodal cells, they are having low amount of sodium ion channels and they are having higher amount of the potassium ion channels, and because of that particular property, they are exhibiting negative dromotropic effect because during the vagal stimulation. So the PR interval, this is the ECG, and they are showing the PR interval QRS complex. So the PR interval already have shown prior, so it will contain all those three intracardiac intervals, PA interval, A to H interval, H to H also, which I have not shown here, and then H to V interval. So first degree AV block, here every atrial impulse is conducted to the ventricle, but the PR interval exceed more than 200 milliseconds in the adults. And the delay will be anywhere from the atrium up to the activation of the ventricles. The commonest level of block in first degree block is the AV node, though it can be anywhere from the atrium to the ventricle. So the first degree block can be due to enhanced vagal tone, could be occur in the well-trained athletes because of some drugs, in case of myocardial infarction, and some degenerative changes inside the conduction system. So it is actually a benign condition and does not require any pacemaker. So this is the one clinical scenario, prolonged PR with the wide QRS escape. Can the block be at the level of AV node? So yes, if the patient having first degree AV block with the prolonged QRS duration, is still the patient having block at the level of AV node. So suppose you can see here, there is a right bundle branch block and conduction is happening from the left bundle branch transeptally, and it is going to the right bundle side. So patient will have a wide QRS rhythm because the right bundle is being blocked, or some amount of delay in the conduction to the right bundle. But still, in addition to the right bundle delay, the patient will have AV nodal delay also. So AV nodal delay will be longer than the delay of the right bundle. So whenever the patient having two types of delay, the patient will manifest the delay which is higher, being higher in amount. So in situation when the patient is having prolonged PR with a wide QRS, likely they will have infra-Hessian kind of or Hessian kind of delay, but still the level of localization in this particular situation can be at the level of AV nodal also. Second situation, when the patient is having prolonged PR and they are having narrow QRS rhythm, can the block be at the level of bundle branches? Can it be possible? So yes, it is a possible thing. So what is so in this hypothetical situation I will discuss. So suppose the impulse is conducted from the AV node to the different fascicles of the conduction system, this Purkinje system. So you can see here, even though the impulse is traveling through a slower rate, but in all three fascicles, the rate of conduction is at a similar level. So whenever there is a delay of equal amount in all the three fascicles, it will still manifest as a narrow QRS rhythm, though the block is at the infra-Hessian level of site. So this is one of the example. This is a pre-tower ECG of a patient who underwent tower. So pre-tower implantation, the patient having right bundle branch block, prolonged PR interval, and having leftward axis deviation. So RBB, prolonged PR, leftward axis deviation, likely that patient is having left ventral hemi block and right bundle branch block. So this is RBB, and then patient is having left axis deviation. Okay, so on the post-tower day 1, patient underwent tower implantation. On the post day 1, you can see the P interval become 270 now, and the QR has become normalized here. You can see the axis become also normal. So what is happened here? So now we will understand. So on pre-tower implantation, patient was having leftward axis deviation, right bundle branch block. So conduction was happening only through the left posterior fascicle, and there was a delay in the left anterior fascicle, and then the delay there was in the left right bundle branch also. So after the tower implantation, what was happened? Because of tower implantation, there was some amount of delay increase inside the left bundle itself or the left posterior itself. So because of that, the delay become equal in all the 3 fascicles. So now what you can see here, now the patient is having prolonged PR because of delay become increased, but the delay is equal in all the 3 fascicles. Now the QR has become narrow. So pre-tower implantation, patient having right bundle branch block with left axis deviation, only left posterior fascicle was being conducted, left atria was blocked, right bundle was being blocked, or there was some delay conduction. And after the tower implantation, now the conduction become more decreased in the left posterior fascicle, and now there is an equal delay in all the 3 fascicles. The QR has become narrow. So site of block, if the PR interval is more than 300 millisecond, the site of block mostly at the level of atrium, could be at the level of AV node, and could be at the level of intrahaesan level also. But if the patient is having bundle branch block, wide QRS escape, PR more than first degree AV block, so site of block could be in anywhere. So this is a first degree AV block with the normal contour of the QRS complex, likely the level of block at the level of AV node, suprahaesan level. This is another example. In the left side, you can see there is a right bundle branch block, and you can see the AH interval was more than 125 millisecond. Here is a 310 millisecond. So this is a first degree AV block, wide QRS escape, and the patient is having suprahaesan level of AV block. On the right side, you can see the patient having left bundle branch block, prolonged AV interval, prolonged PR interval, and the HV was being prolonged more than 55 millisecond. Now here it is a 95 millisecond. So first degree AV block with wide QRS escape, the level of block can be anywhere. It can be in a suprahaesan level, it can be at the level of infrahaesan level also. To decipher the site of block in this example, there is a right bundle branch block, prolonged PR interval, and the patient underwent slightly leftward axis. The patient underwent EP study, and they found there was a HV interval was more than 55 milliseconds. So it was a infrahaesan level of AV block. So clinical significance, this study of more than 7,000 patients and follow-up of more than 30 years, and they have found this kind of patients, first degree AV block, their higher amount of risk of developing atrial fibrillation, higher amount of those patients develop pacemaker implantation, and first degree is actually a proxy for the alteration in the cardiovascular system. So in conclusion, first degree AV block with wide QRS escape, likely the block at the level of infrahaesan level. Though the same situation, first degree AV block with wider QRS escape, site of block can be anywhere in the conduction system, at the AV nodal level, suprahaesan level, or also in the infrahaesan level. Coming to the second degree AV block, second degree AV block, it divided into 2 types, Mobitz type 1 known as the Wenckebach phenomena, and Mobitz type 2. So in Mobitz type 1, there is a progressive delay in the PR prolongation and followed by a blocked P wave, and there will be a pause followed by the blocked P wave. So pause duration will be less than the twice of the PP interval. So the mechanism is that AV nodal has a relatively longer relative refractory period, so that each incident impulse conduct with some delay. So earlier the impulse arrives at the AV nodal level, the longer time it will take to conduct. So shorter the RP, longer the PR. Shorter the time AV nodal being depolarized, longer it will take time to become again active. So this is known as the RP-PR reciprocity. So when the impulse arrives at the absolute refractory period, the P wave will not conduct. So the criteria for typical Wenckebach given by the Wenckebach long back. So what they have told, there is a progressive lengthening of the PR interval with the largest increment between the first and the second conducted beat. So suppose at the first beat the PR interval was 200 millisecond, and the second beat it become 300 millisecond. So the increment was 100 millisecond, and the third beat it should be less than 100 millisecond. that is what they mean by the first sentence. In the second thing, there is a progressive increase in the PR interval resulting in decrease in the RR interval. That we will understand in the ladder diagram. Third thing, duration of pause. The duration of the pause, so all those things we will understand through the ladder diagram. So this is a study done in the 1975 by Pablo Dennis, and what they have shown, they have found out that they have studied the incidence of typical and atypical Winkebeck periodicity, and they have found when they did atrial pacing for the Winkebeck periods, they have found only 34% of the patients are going to have typical finding of the Winkebeck period, and 66% patients having finding of atypical Winkebeck periodicity. And on other thing, they have also studied the spontaneous Winkebeck periods. So in that, what they have found is still the 14% patients only showed the typical Winkebeck phenomena, and more amount 86% of the patients, higher number of the patients showed atypical Winkebeck phenomena. So they have told that typical Winkebeck phenomena is an exception rather than the rule. And also they proposed to abolish the term typical and atypical Winkebeck phenomena, and they told 3:2 conduction ratio cannot be classified as a typical or atypical since there is only one increment present in the 3:2 conduction. So what you should remember, this is a this is the simplified version of Winkebeck phenomena. So what you will find a group beating. There will be group beating of the RR interval. That is a hallmark. Progressively prolongation of the PR interval throughout the sequence. First delay in the PR will be highest compared to the subsequent PR interval. There will be shortening of RR interval. The P wave preceding the blocked P wave will have the longest PR interval in the sequence. The RR interval containing the blocked P wave is shorter than the sum of the twice of the PP interval. The PR interval of the beat following the blocked P wave has the shortest PR interval in the sequence. The PR interval that being conducted after the blocked P wave, that will have the shortest PR interval, and there will have RP PR reciprocity. So these things we will understand through this ladder diagram. So you can see here the P wave formed by the duration of 1000 millisecond, then there was the AV delay, and then subsequently QR is being formed. So in the first, AV nodal delay was 200 millisecond. In the second beat, the AV nodal increased by 100 millisecond. So now the RR interval being formed by the 1000 plus 100 millisecond of delay, and it will form by a duration of 1100 millisecond. On the third beat, further increment, but increment was only 50 millisecond now, from 300 to 350, and the next RR interval being formed by the 1050 millisecond, 1000 millisecond duration of the P wave and the 50 millisecond delay at the level of AV node. So you have to see the absolute increase, not this 200, 300 or 350. You have to increase. You have to see the absolute increment. From 200 to 300, there is a 100 millisecond increment. From 300 to 350, there is a 50 millisecond increment in the AV nodal delay. So you can see there is a progressively increase in the PR interval, 200 to 300 to 350. But also you need to remember that this absolute increase is on the lesser side. First increment was 100 millisecond, second increment was only 50 millisecond. So progressively increase, the last PR being conducted was the highest in number, 350, and subsequently the P waves got blocked, and the again beat was conducted with the shortest PR interval. And the duration of the pause will be less than the twice of the PP interval. So you have to minus the actual absolute increase in the PR interval in the last two beats. So first beat increased by 100 milliseconds, second beat increased by the 50 milliseconds, so total increase was 150 milliseconds. So you have to minus off 150 milliseconds from twice of the PP interval. So it becomes 1850 milliseconds. So progressively increase, absolute increase will be on the decreasing side. There will be RR crowding because first bit R came at 1100 millisecond cycle length, second R bit came at the 1050 millisecond. So RR become progressively shorter, and the pause will be less than the twice of the PP interval. So all those things we have discussed, what we have found out in the previous slides. So atypical Winkebeck phenomena, here you can understand that first AHs were 240, then second AH was 280, 290, 295, 295, but you can see the last AH interval become 325. So progressively there is some increment, but the last beat become more increased in the amount as a 325 millisecond. So this is the atypical Winkebeck periodicity. So this is one of the example. RR being crowding is seen here, and progressive lengthening of the PR interval you can also observe here. So this was the typical Winkebeck periodicity. So in this particular example, you can see the level of block at the level of supra-ACN level, A to H become prolonged, and then A followed by no H and no V. Coming to the site of block, the common site is AV nodal, 8 to ACN delay. The less common site could be at ACN or infra-ACN level. If it is a ACN, there will be H to H delay. In case of infra-ACN, there will be H to V delay that we have to offset in the LGM. Coming to the clinical significance, it could be due to the high vagal tone. It is common in the athletes. It could be asymptomatic patient usually does not require any kind of treatment. Symptomatic patients with bradycardia or with intra or infra-ACN AV level of block may require pacemaker. Coming to the type 2 AV block, it is termed as the Mobitz type 2 AV block. There will be no PR prolongation and no PR prolongation preceding the blocked P wave. The pause will be twice the basic QP interval. So in this ladder diagram, we need to understand. So this is a P wave being formed at the level of 1000 millisecond. Then A to H was 80, H to V was 85 millisecond, and the V wave being formed. And the second bit also having same thing, third bit also having same thing, and the fourth bit A to H came at 80, and then H wave being blocked at the level of infra-ACN level, and the V wave does not form. So again the next bit came at the same cycle length. So here you can see the pause was twice of the PP interval. Here it is a 2000 millisecond. So there is no PR prolongation, sudden P was being blocked, and the pause duration was twice the PP cycle length. So this is termed as a Mobitz type 2 AV block. So this is one of the examples. Some P wave being blocked here. Patient underwent EP study, and they have found that the block at the level of infra-ACN level. A to H came, but V does not came. So site of block in Mobitz type 2, it is generally not at the level of AV node. It is always at the level of infra-ACN region, and we need to diagnose in EP study to see whether H is not followed by the V wave during the blocked P wave. But this is not always true, that sometimes the Mobitz type 2 block can happen at the level of AV nodal also. So clinical things, if Mobitz type 2 block is present, it usually indicates his Purkinje system is being diseased, and it is usually not seen in the healthy individuals. There is a high chance, if it is present, it being progressed into the high grade AV block. But if it is seen in the young individuals with some asymptomatic type 2 AV block during the sleep, it is not true that the block is happen actually at the level of the infra-ACN level, because sometimes it is being explained by the concealed junctional ectopics or AV wingback with a non-measurable delay in the PR interval. Coming to the advanced or high grade AV block, it is termed as a more than 2 P wave not being conducted, and the site of block is mostly could be at the level of AV node, could be at the level of his Purkinje system. They usually required a pacemaker. So this is the high grade AV block where the 3 P wave beats, 2 P wave beats was not conducted, and the third beat was conducted. Coming to the 2 to 1 AV block, it is a separate phenomena. It is not comes under the Mobitz type 1 or Mobitz type 2. Here every other P wave beat is being conducted. So in 2 to 1 AV block, how we can determine the level of AV block? So we will understand the effect of delay in the intracardiac intervals on the PR interval. So suppose this is a hypothetical scenario, and P2A interval in this PR segment, P2A was 20 millisecond, A to H was 80 millisecond, H to H was 10 millisecond, H to V was 40 millisecond, and the total PR interval summation of all these intervals was 150 millisecond. And suppose I have increased the AH interval by 200%, so it will be increased by 3 times. P2A was 20, and A to H from 80 it become 240 millisecond. H2 remains the same 10 millisecond, H2 was 40 millisecond. So the total PR here is 310 millisecond. Second scenario, we have increased the 200% delay at the level of intra-ACN level, H2H. So P2A remains the same, A2H remains the same. Now H2H from 10 millisecond it becomes 30 millisecond, and H2 remains the same. So the total PR interval being here is a 170 millisecond. Fourth thing, now we have increased the 200% delay at the level of infra-ACN level. So P2A is 20 millisecond, A2H is 80 millisecond, H2H is remain the same, but H2V now become from 40 to become 120. So now the PR interval being here is a 230 millisecond. So what is the observation here? So if you have similar kind of increment in the intercardiac intervals, A2H, H2H and H2V, we have increased a similar amount of increment. You have increase by 200% increment here. So the maximum amount of effect of intracardiac interval will be reflected in the PR interval by the suprahesion level. So for the similar percent of increment in the intracardiac intervals, the PR interval being prolonged is maximum at the suprahesion level of AV block, because the AH interval is normally it carries the value of 55 to 125 milliseconds. So if you do the similar kind of increment, the maximum effect on the PR interval will come under the effect of AH delay, that is the suprahesion level of delay. So if you see a patient who is having more than 280 or 300 milliseconds of first degree AV block, likely the patient is having suprahesion level of AV block. 2:1 conduction with longer PR is likely to have a suprahesion level of delay or block. Second thing, effect of sympathetic in the parasympathetic stimulation. Suppose this patient having 2:1 AV block, so this PV is being conducted, another PV is being blocked here, and another PV was being conducted. So 2:1 conduction is happening here, and you have given a tropin. So once you have given a tropin, you are going to stimulate the AV node and the sinus node also. So because you are going to improve the AV nodal conduction, so this 2:1 may become 1:1 also. So if it is a suprahesion or level of AV block, sometimes this 2:1 become 1:1. So if you do exercise also, same thing can happen, 2:1 may become 1:1. So sometimes the AV nodal refractive periods are high or because of some vagotonia. So if you give a tropin, this level of 2:1 AV conduction sometimes may improve also. But what happens if you are giving atropine exercise to a patient who are having 1:1 conduction or 3:1 conduction? From 1:1 become 3:1, or from 1:1 become more wider escape. So what is the reason here? So suppose this patient is having this PV is being blocked, another PV being blocked at the Hessian level, and the third PV was being conducted. So 3:1 phenomena is happening here, and you have given atropine. So once you have given atropine here, now the AV nodal conduction is being improved here. But what is going to happen? Now every impulse is being transmitted to the His Purkinje system, which is already being diseased. Their refractive periods are high. So when each impulse travels to the His Purkinje system, they are not going to, the refractiveness is not going to improve. They become worse and worse again. So now what will happen? If it is still initially it was connecting partly, now there will be complete block at the His Purkinje system, and there will be wide QRS escape. So if the patient is having infrahesian level of AV delay, and if you are giving atropine, all the conduction become more worse. From 1:1 it may become 3:1, from 3:1 it may become 4:1, and sometimes the QRS may become more and more wider. So if you give atropine, the conduction become worse. It signifies the patient is having infrahesian level of AV delay or AV block. Suppose you are giving opposite thing. You are giving here a carotid sinus massage or some vagomimetic drugs you are giving here. So what will happen? So once you are giving carotid sinus massage, the parasympathetic activity will become high. The AV nodal now become refractory to conduct because of the parasympathetic effect. But because AV nodal refractoriness become increased, the lesser amount of the impulse will travel towards the His Purkinje system. The lesser amount of the impulse travels to the His Purkinje system, the higher it will recover from the refractiveness, and the condition may improve also. So in case of infrahesian of AV delay, if you do carotid sinus massage, if the conduction improve from 3:1 to 2:1, from 2:1 to 1:1, likely it suggests that patient may have infrahesian level of AV delay. So sympathetic stimulation may worsen the infrahesian conduction delay, and parasympathetic stimulation may improve the infrahesian level of AV delay. So concept is already have told here. If there is a suppression level of AV block, sympathetic stimulation will improve the conduction. If there is a site of delay at the infrahesian level, sympathetic stimulation will worsen the conduction. If the site of delay is suprahesian level, parasympathetic stimulation will worsen the conduction, and in case of infrahesian site of delay, the parasympathetic stimulation will improve the conduction. So autonomic drive will directly affect the suprahesian level, and they will indirectly affect the infrahesian level of block. Coming to the QRS duration, how can we determine the level of block by means of QRS duration? So this is the 2:1 AV conduction with QRS of normal contour, So here EP study showed that the patient is having intra-ACN level of AV block. You can see the H impulse are splitted. The H potentials are splitted. You can see there is a splitted HH potential. So even though the patient is having 2:7 AV conduction with narrow QRS rhythm, the patient having intra-ACN level of AV block. Another example, there's a 2:7 AV conduction is happening here with right bundle branch block, and when the patient underwent EP study, you can see there's a AHV, A came and H and V does not came. This is our right bundle branch block, so A came, H and V does not came. So even though the patient having wide QRS rhythm, 2:7 with the wide QRS RBB, is still the level of block at the level of supra-ACN level. So QRS duration basically does not very much help in deciding whether the patient is having supra-ACN or infra-ACN level of AV block. So 2:1 AV block with wide QRS duration, likely the patient will have infra-ACN block, but AV nodal delay is also possible. And if the patient having 2:1 AV conduction block with a narrow QRS duration, it does not exclude the infra-ACN level of block. Still the patient having intra-ACN level of block can also be possible. So this is another example. There's a 2:1 AV block with a varying PP interval. You can see here. So you can observe here that in between those P wave, there is a QRS and QRS complex. So whenever the QRS complex is occurring, the PP interval is being shorter, and whenever there is a no QRS complex, the PP interval become longer. So what is the reason being here? So this is termed as a ventriculophasic response. So what is happening here? Whenever there is a contraction in the ventricle, the AV nodal will get better supply. The sinus nodal artery will get better supply. So that is why the sinus nodal activity will discharge faster and the P wave become earlier whenever there is a QRS complex. So this is termed as a ventriculophasic response. So level of block in case of 2:1 conduction. So if you see the QRS duration, it may become wider and narrower if the site of block at the level of AV node. In his bundle also same thing can happen, but if it is a actual bundle branch, it is always will be wider. Mostly it will be wider. Effect of PR interval, higher the PR interval, higher likelihood that the patient may have site of delay at the level of AV node. So more than 280 or 300 milliseconds site of delay will be AV node. In case of his bundle, it will be less than 160. In case of bundle branches, it may be vary between 160 to 200. In case of carotid sinus massage, when you stimulate the parasympathetic system, it will worsen the AV nodal conduction. But because it is worsening the AV nodal conduction, now the impulse is not being transmitted. Not every impulse being transmitted to the his bundle region. So his bundle will getting better time to recover from the refractoriness. So the conduction will improve if the level of block at the level of his bundle. And the bundle branches also it will happen the same thing. Atropine and exercise will have a similar effect. AV nodal conduction will improve. Now the every beat is being conducted to the his bundle level. Their refractoriness will become more and more higher. They're not able to recover, and the conduction will become worse. Same thing will happen at the level of bundle branch. Exercise will have similar effect to that of atropine. So in 2:2 AV block, it usually warrants pacemaker, and atropine should not be used. If you see a wide QRS rhythm, 2:1 AV block with wide QRS, you should not give a atropine to this kind of patients. Coming to the third degree block, there will be no atrial activity. The AV node is being completely blocked. There will be independent pacemaker inside the atrium and the ventricle. So third degree block, it can be blocked at the level of supra-ACN, could be at the level of infra-ACN. If the QRS duration is less than 120 milliseconds, likely it is a supra-ACN. Rate of discharge be between 40 to 60 beats per minute. Usually the cause become congenital cases usually have this kind of finding. With the infra-ACN, they usually acquire this kind of block. The rate will be very less than 40. The QRS duration will be more than 120 milliseconds. So this is one of the case having complete heart block with a right bundle branch block escape. And here the AP study showed that the patient is having infra-ACN level of AV block. A to H came and V does not came. So patient is having infra-ACN level of AV block, even though the QRS was narrower. So in case of AF, you have to recognize whether the patient is having complete heart block or not. So in case of atrial fibrillation, if you see the RR interval become regular, it is likelihood that the patient is having complete heart block. Because in case of atrial fibrillation, there will be irregularity in the fibrillatory waves. So it should be irregularity in the QRS complex also, But if you patient develop complete heart block, AV nodal block, so the irregularity of those fibrillative waves not being transmitted to the ventricle, and the RR will become regular because of the junction escape, or sometimes it become wider also if it is an infra-ASN level of block. But RR will become regular if the patient is having AF with complete heart block. In case of flutter also, you need to recognize whether the patient is having complete heart block or not. So in the rhythm street, you have to observe whether the first beat and the last beat having similar amount of PR interval, similarity between the PR interval. If those PR interval are being different, higher likelihood that the patient is having complete heart block. So AV dissociation is not a primary disturbance of the rhythm, but it is actually a symptom of the underlying rhythm disturbances. So if the patient is having slowing of the dominant pacemaker, that is a sinusoidal depression, the junctional rhythm will take over and the patient may have AV dissociation. If the patient is having acceleration of the latent pacemaker, suppose the patient having ventricular tachycardia, still they may have a AV dissociation. So sinus bradycardia will also have a AV dissociation, or VT also can have a AV dissociation. So this is one of the example where is the sinus bradycardia with the junctional escape with the AV dissociation. So at the starting we have discussed, we will fill the blanks of the level of block in case of AV nodal delay or AV nodal block. So if the first degree AV block, the level of block can be anywhere from the atrium till the bundle branches. In case of second degree AV block, in case of Mobitz type 1, it can be at the level of AV node. Rarely it can be at the level of his bundle or bundle branches. In case of Mobitz type 2 AV block, it can be at the level of his bundle, mostly at the level of his bundle and bundle branches. Rarely it can be at the level of AV nodal also. In case of 2 to 1 AV conduction, block can be anywhere from the AV node till the bundle branches. In case of high grade AV block, it usually at the level of his bundle or bundle branches. In case of complete heart block, it can be anywhere from the supra-ASN till the infra-ASN level. So we are coming to the special circumstances of this AV block. So can Mobitz type 2 AV block can happen at the supra-ASN level? So patient is having Mobitz type 2 AV block and the level of block at the level of supra-ASN level. So this is one of the example. This is a study done in 1971. So Joseph et al. They have studied of this Mobitz type 2 AV block. So what they have found here, you can see in this rhythm street PQRS complex, first beat PQRS, first P is again connected with the QRS complex, third beat also being connected from P to QRS, and the final fourth bit P wave is there, but there is no QRS. So when they did the EGM analysis of this patient, so what they have found, A, H and V, again A conducted through the H and then V, third bit also having A conducted through the H and V, and the final bit is having only A, there is no H. So you can see the PR interval was fixed, the QRS complex RR interval was also fixed. Still one A beat or one P wave beat was not connected, and the level of block at the level of supra-ASN level. So A came and H does not came. So there is a Mobitz type 2 AV block and the level of block at the level of supra-ASN level. So this can happen in a normal individual also. Whenever you pace faster and faster to the some of the patients in the EP lab, this finding you can observe. Sometimes the P wave or the atrial pacing impulse will come at the level of absolute refractive period of the atria. At that particular time of absolute refractive period of the AV node. So at that particular time A will come and the H wave will not come. So this can happen normally also. If you pace faster and faster, then only you can have, you can have this kind of finding. Second thing, Mobitz type 1 Winkelbeck phenomena at the level of infra-ASN level. So this is also atypical finding. So this is one of the example. This study, this case report by the Sudhita Mondal et al. So what they have found here, you can see this is the patient is having right bundle branch block intermittently and having right axis deviation, and intermittently they have a left bundle branch block. Intermittently some PV are being conducted, some PV are being blocked. So we'll study this particular rhythm strip in the ladder diagram. So here you can assess here. So first beat you can see having right bundle branch block morphology. So it is being conducted to the left interfascicle, right bundle being blocked. In the second beat again you can see the PV being blocked here. In the third beat you can see it was a right bundle branch block morphology. It is conducted through the only left intervesical. Fourth beat, again you can see right bundle started conducting and left intervesical is still conducting. Fifth beat, again patient is having right bundle branch block morphology with left intervesical being conducted here. Sixth one, patient having LBB morphology, right bundle being recovered. Seventh beat, P wave being blocked. Eighth beat, again patient right bundle recovered here. Ninth beat, patient having right bundle branch block, on left intervesical being conducted. 10th beat, again the patient is having right bundle branch block and being conducted through the left intervesical. So if you observe the PR interval here, in the first beat the PR was 280 millisecond, second P was blocked, and the next beat which is conducted now, it is conducted at the level of 200 millisecond. So it is just, we can observe here there is some kind of Winkebeck periodicity in the left intervesical. The last beat which is being conducted before the pause having PR of 280 millisecond, and after the pause the PR being conducted at 200 millisecond. So that is the shortest PR after the pause. So this gives us clue that there is some Winkebeck periodicity is happening at the level of left intervesical, because before the pause right bundle is also blocked, and in the last second beat also after the pause, first beat also after the pause, right bundle is being blocked. Then fourth beat PR is 160, fifth beat PR is 260, sixth beat PR is again 160. So here intermittently right bundle is being conducted, so you cannot observe any Winkebeck periodicity in the left intervesical. Seventh beat was blocked. Eighth beat the PR was 160. Ninth beat the PR was 220 millisecond, and the 10th beat the PR become more higher, 280 millisecond. So in the last three beat, 8th, 9th and 10th, you can observe here there is a progressively increase in the PR interval in the left intervesical. So when the right bundle was being conducted, the PR was 160. When the right bundle being blocked, only left intervesical is being conducted, the PR is increasing from 220 to 280. So there is a progressively increase in the PR interval. So this is the type of atypical Winkebeck periodicity at the infrahissane level, at the level of left intervesical. Coming to the pseudo AV block, it is an apparent first degree or second degree AV block in the absence of any AV nodal conduction, in the absence of any AV conduction system abnormality. So suppose this is one of the EGM, you can see first bit having AH and V with the AH of 100 millisecond. Then his extrasystolic beat came, but is not conducted, but somehow it penetrated inside into the AV node. So because of that, AH is increased to 120 millisecond, and in the third beat you can see there is his extrasystolic beat came, and after that one P wave came which is not been conducted. So it appears that there was a Mobitz step 2 AV block is happening here, but this we will understand in this ladder diagram. So here you can see this is the AH, HV and the V interval. His extrasystolic bit came, it is not bit conducted anteriorly or retrogradely, but subsequently in the next beat the AH interval being prolonged from 100 to 120 millisecond, because his extrasystolic beat penetrated inside the AV node. Subsequently you can see again his extrasystolic beat came, retrogradely it collided with the P wave, so the P wave is not been conducted to the ventricle, and antegradely it is also not powerful enough to generate any QRS complex. So it appears like this beat is being blocked. This is like a Mobitz type 2 AV block, but actually this is not a pathological block, it is a physiological AV block, and this usually does not require any kind of treatment. So how we will recognize this? With a sudden appearance of PR prolongation in the ECG rhythm, you have to suspect this. And if you see there is occurrence of type 1 and type 2 AV block, Mobitz type 1 and type 2 AV block in the same patient, you have to suspect this kind of phenomena. Clinical significance, they usually does not require any pacemaker and usually suppressed by the medications. Then the fourth thing is a sudden AV block by an APC or VPC. So what is happening here? You can see there is a 1:1 conduction, then suddenly all the P waves being blocked. This is another example. You can see here the one VPC came and followed by all the P waves become blocked. And this is another example, when APC came and after that all the P wave become blocked. So all this ECG strips what I have shown here, there is a sudden AV block which is following any APC, VPC, sometimes spontaneously also. So what is happening here? So this phenomena is explained in the phase 4 AV block, and in these cases there is a from one pseudo AV conduction to the sudden development of the complete heart block. It's seen in any age group, and mechanism is that a phase 4 block in the His-Purkinje system. So normally in the His-Purkinje system you won't see any phase 4 activity of the action potential. Whenever the impulse, whenever there is a completion of the phase 3, the impulse will arrive and the patient will start developing action potential. So in case of disease His-Purkinje system, what is happening? Whenever there is a pause, the phase 4 activity of the His-Purkinje system will start. So the phase 4 activity will start here. The patient is having disease His-Purkinje system. So what has happened? When the phase 4 starts, some amount of sodium channels are being activated here. And now whenever the impulse came to the His-Purkinje system, already some amount of sodium channels are being opened. So whenever the impulse arrives, there is not much enough sodium channels to depolarize. So it will not able to generate the action potential. So because this long pause, sometimes because of long pauses, if the patient having disease His-Purkinje system, they will start developing phase 4 activity. And because of phase 4 activity, whenever the impulse arrives at the phase 4 level, it will not able to generate the action potential, and patient will develop complete heart block in terms of the PO will be not connected to the ventricle. Coming to the pseudo-Mobitz type 2 AV block, it is a vagal mediated AV block. It can be appear like a paroxysmal type 1, second degree or third degree AV block. There will be simultaneous slowing of the both sinus node and the AV nodal conduction. It occurs more often during the night time, but the daytime also possible in some cases. It can be produced by the cryptic sinus massage. Sometimes tiltable tests also induce this kind of findings. So site of block is usually at the level of AV node, and the vagal input usually depresses the sinus nodal function and the AV nodal conduction, and it does not have any influence on the velocity of the His-Purkinje system. So this is the strip showing the pseudo-Mobitz type 2 AV block. There is a PP interval being prolonged from 1120 to 1160 to 1280, and the PR interval also being prolonged here. So simultaneous prolong of the PP interval and the PR interval suggests patient may have pseudo-Mobitz type 2 AV block because of a vagal mediated. So usually these patients medically managed. They does not require any kind of attention unless they are very much symptomatic. So as per the guideline, Mobitz type 1 is a patient with symptomatic and they are having neuromuscular disorder with progressive conduction disorder. They are class 1 recommendation for the pacemaker. In case of Mobitz type 2 AV block and high grade AV block with complete heart block, they are usually having class 1 indication for the pacemaker. So in case of AV nodal block, high grade AV block or Mobitz type 2 AV block, if they are managed conservatively, they are having poor survival compared to those patients who are under pacemaker implantation for the similar situation. So concluding the first part of this lecture, the Mobitz type 1 AV block can happen at the level of His-Purkinje system. The Mobitz type 2 AV block can happen at the level of AV node. It is important to rule out the physiological causes of AV block versus the pathological causes of AV block. If the block happens at the level of SA nodal level, it is important to determine and assess the symptoms which are more important to assess for the pacemaker